Good evening. On behalf of the Immunodeficiency Foundation, welcome to this evening's forum, Gastrointestinal Issues and Primary Immunodeficiency. I'm Kathy Angela, Vice President of Education at the Immunodeficiency Foundation, and I would love to thank you for joining us tonight. This forum is being recorded. And tomorrow you will receive an email from IDF. It will include a link to a very short survey, which we hope you will fill out and let us know how we did tonight and what topics you would like to hear about at future forums. As always, a quick disclaimer, please remember that the information presented during this event is not medical advice, nor is it intended to be a substitute for medical advice, diagnosis, or treatment. Please always seek the advice of a physician or other qualified health provider with questions concerning a medical condition, and never disregard professional medical advice or delay seeking it based on information presented during tonight's event. During tonight, questions can be submitted into the Q&A box icon. You will see that probably at the bottom of your screen. And if you are having questions for any of us behind the scenes that are not related to tonight's topic, just send that in through the chat. And we are ready to move forward. And again, so glad to have you with us this evening. IDF's mission statement. The Immunodeficiency Foundation improves the diagnosis, treatment, and quality of life of people affected by primary immunodeficiency through fostering a community empowered by advocacy, education, and research. And for over 40 years, the Immunodeficiency Foundation has served as the trusted organization in the primary immunodeficiency community by providing accurate and timely information, resources, and support for individuals with PI and their families. Whether you're an individual with PI, a family member, a friend, or a healthcare provider, IDF is here to help. When you have questions about living with PI, health insurance, or more, simply go to the IDF website, click on Ask IDF right at the top of the screen, submit your question, and a staff member will follow up with you. If you're looking for support, there are a couple different options. One option is to attend a Get Connected group. IDF Get Connected groups are virtual events. Some of them are now turning back into in-person events. And this is an opportunity for individuals who are diagnosed with PI or have a family member with PI to get together in a small group setting and to meet others, receive support, and also share support with others. And another option, if you think, I'm not really into a small group setting, I would prefer one-to-one support, that's also an option. Contact us through Ask IDF, say I would like one-to-one support, and we will have one of our wonderful peer support volunteers follow up with you. Upcoming forums and events. Well, this weekend, if you live in the Baltimore, Maryland area, on Saturday at the brand new IDF office, which I just saw a wonderful blog article come out today about, you can go to our office and attend an in-person meeting and have your questions answered, meet our wonderful sponsors, some of our wonderful staff members, and of course, our wonderful medical presenters who volunteer their time to be there that day. And then upcoming forums would be on December 7th. We have a forum about Good syndrome. December 14th is a year-end celebration for Walk for PI. It's virtual. And then the last forum this year is on December 15th, and it is COVID-19, flu, and RSV. Oh my. And We are looking forward to sharing as much information about all those topics with you as we can on that final forum of 2022. Our forums are made possible by our wonderful sponsors, and it is due to their partnerships and contributions that we are able to provide programs such as this one to everyone in the PI community. So please join me in thanking this year's sponsors: CSL Behring, Grifols, Takeda, Horizon, Accredo, Octapharma, ADMA Biologics, AstraZeneca, Farming, X4 Pharmaceuticals, Kedrion Biopharma, Enzovant, and Chiesi Global Rare Diseases. They are important in our community because they provide that life-saving therapy and care that each of us needs. So thank you to our sponsors. And during the evening, you will hear from one of our sponsors in just a second here. And then there will be some short video clips from our sponsors talking to us about support that their companies offer. So at this time, I am excited to introduce Joanna Maltese from Octapharma for a word from our sponsor. Joanna, take it away.
Thank you, Kathy. It's great to see you. As Kathy mentioned, my name is Joanna Maltese, and I'm a clinical nurse educator in immunology at Octapharma. Our first slide is showcasing our IG Cares support program. Would you mind projecting the next slide, please? Octapharma has long supported the IDF because we believe in the mission of education, support, and community. And so we have designed igcares.com to provide just that to the PI community. It doesn't matter whether you take any of our products, there is information and resources there on that site for you. We have stocked it with lots of education about PI. Again, not just about medication, but about PI and living with PI. There is a peer support program that we offer as well that you can access through the IG Cares program. There is a program that enables you to give to charities like the IDF simply by reading articles, and it's completely free to you. And Octapharma will turn your donations into dollars and donate them on your behalf. Next slide, please. For our patients who use Q2Quig, there is a copay assistance program that is also accessible through the IG Cares program. There is an infusion app, and there is also a recycling service for all of the medical waste that's generated during a subcutaneous infusion. So please scan the QR code for more information, but we're happy to be here supporting you and supporting this community. Thank you for your time and enjoy your program this evening. The last slide is just the box warning that we have to show. Thank you.
Thank you so much, Joanna, for being here tonight. And thank you to all of your colleagues at Octapharma who provide information and support and products for the PI community. And now a quick word from our sponsor, ADMA Biologics. So at this time, Dr. Glover, I am going to stop share and we will get your slides up. And thank you. Thank you for being here.
Thank you for having me. And thank you, Kathy, for your service to the community. It's been amazing. So this is actually, I realize this is probably the third or fourth time I've given this talk. So it is not the same talk I gave last time. I did edit it and added some new stuff. I was trying to remember back to the last time I gave it, some of the questions that I got, and then also included some of the data that we have on COVID that I thought all of you might find interesting. So these are my disclosures. Here's some objectives. We're going to talk about immunology of the GI tract. We're going to talk about infectious GI disease. We're going to talk a little bit about COVID-19 and the microbiome, inflammatory GI disease, nodular lymphoid hyperplasia, some stuff about liver and biliary disease, cancer and neoplasia, diet and probiotics. And I don't know why I put COVID at the end, but it's supposed to be up higher. So I actually borrowed this from one of my colleagues simply because I like it. So when you think about the GI tract, it's really a barrier tissue. So it provides protection. And, you know, there's a lot of adaptation that occurs there and a lot of memory. And there's things that are inputted. So those are like the microbial things that are there, abiotic things. I guess IgA would be considered an abiotic thing, and things injury. And this can include, you know, skin, gut, airway. For the purposes of this talk, we're really going to focus on, oh boy, what happened here? Okay. For the purposes of this talk, we're really going to focus we're going to focus on the gut. And then there's outputs, there's defense, there's metabolism, there's repair. And these barrier tissues really have like an epithelial surface, they have stromal cells, they have hematopoietic cells, and there are nerves that kind of underlie them. All right, where are we going? Okay, there. So this is kind of the normal gut barrier. So you have the microbiome here, you know, all the fecal stream that's going through. You have the epithelial lining, and then you have lots of different immune cells, dendritic cells. You have natural killer cells, you have innate lymphoid cells, you have neutrophils, you have macrophages. We're going to talk a little bit about macrophages later, and T cells. T cells and B cells are something that, as the PID community, we've spent a fair amount talking about. We also think about GI-associated lymphoid tissues. These are really present more in the ileum, but they are very important to the gut. And defects in these GI-associated lymphoid tissues are particularly important in primary immune deficiencies, including lack of plasma cells. So when we think about primary immune deficiencies, and we're just going to niche in and just kind of think about CVID enteropathy, but I think this can be applicable across other primary immune deficiencies that affect the gut. You have an immunodeficiency, you get immune dysregulation, you can have autoimmunity, there's some alterations in the gut microbiota, there's obviously genetic factors, infections, and cancers. We're going to go through some of these things. I realized after that I probably need to update this, because even in the pandemic, there was a new update for inborn errors of immunity that just came out. That's actually very nice. And there's a good table. I decided not to include it in this slide deck, but it's actually quite a nice update on some of the inborn errors of metabolism. And so I think in this COVID pandemic, we've learned more about that. But there's more than 350 primary immune deficiencies, and about a third of them have a GI component. Their GI symptoms and complications are often the initial signs of a primary immune deficiency. And you can see infectious diarrhea, inflammatory diseases, liver problems, some oncological diseases, malabsorption. And treatment of replacement Ig is often doesn't fully reverse these. It helps, but it doesn't fully reverse these. So trying to move some. So let's talk a little bit about infectious diarrhea, okay? So this can be, we know that there can be defects in humoral immunity, so that increases your risk of bacterial and viral infections. There's defects in T cells that can increase risk of viral and fungal infections. If you have defects in both, you could risk for bacterial, viral, and fungal infections. And if you have impaired phagocytosis, you could have a risk of bacterial and fungal infections. So what infections should we look for? So in CVID, we really think about bacteria, viruses, fungus, and parasites. So the bacteria are Campylobacter, Salmonella, H. pylori. It was interesting because in the pandemic, I actually saw way more Salmonella and Campylobacter. I don't think Jackson's water problem helped that. It is fixed, by the way. Lots of people have asked me. The federal government came in and really helped. CMV and norovirus. We've been seeing a lot of norovirus in the last several months. Candida infections, Cryptosporidium, Giardia. If you have selective IgA deficiency, sometimes you can get parasites, including Giardia, and that can oftentimes be the presenting thing. XLA and some hypogammaglobulinemia, again, Campylobacter, Salmonella, Shigella. Viruses would be rotavirus, Coxsackie virus, echovirus, and then, the parasites mentioned above. And really these diagnoses can be done with stool culture, stool ovin parasite, or GI PCRs. And these GI PCR panels are becoming more common. So SARS-CoV-2, at the time I put this slide together in 2020, had just come on the scene, and really, we knew a little bit about it. I published a paper on the microbiome and COVID. We were seeing a lot of people with GI symptoms, but we didn't know as much as we know now. But before I move on to discussion about COVID, because I want to give you a little bit of a snippet of some of our data, really generally, we treat infections that affect people with primary immune deficiency based on the test results from the lab testing of the cultures. And sometimes it's a better treatment of the underlying primary immune deficiency. If you've Candida, you're going to get an antifungal drug. If you have CMV colitis, you're going to get an antiviral drug, but it really just depends on what the underlying cause is. And the treatment landscape for COVID-19 is really shifting. The advent of Paxlovid, I think, has been quite helpful. Some of the antibodies that we originally developed or were originally developed for treatment of COVID are no longer effective with some of these new strains. But it's definitely been a very interesting couple of years. So I wanted to share some of the data that we put together, and I consider myself sort of the accidental physician scientist, because sometimes I stumble into questions that I have or projects just because they're interesting. And as a mucosal immunologist, I have wondered about how viruses impact mucosal surfaces and really act as an environmental hit, triggering gut inflammation. And COVID-19 sort of provided that perfect opportunity to get some answers about how a virus was affecting a mucosal surface. And in this case, we looked at the nose, the nasopharynx, and how we could look at it as a function of different, viral subtypes over time. So basically what we did is we took nasopharyngeal swabs. We used flock swabs that just gives you kind of what the nasopharynx looks like. And by doing these swabs, we were able to get data via single cell sequencing. And single cell sequencing is the hot thing. This is basically an ink blot. You assign a genetic tag to a specific cell, and it basically shows you where it is in space and how many of those cells are present. It's called a UMAP. So if you'll see these, this is the kind of the next latest and greatest thing. And I would say the pandemic really made single cell sequencing take off. So for our original project, we actually looked at 32,588 cells. And this was a particularly interesting project because we were able to generate some open resource data about COVID-19 in the nasopharynx. We were really able to better identify some of these epithelial cells, what's there, what's new, what's not. We looked at lots of different cell types, these goblet cells, deuterosomal cells, secretory cells. And then we were able to identify virus-containing cells and figure out which cells had the highest virus. Interestingly, in this particular cohort, it was goblet and secretory cells. But the most important thing, and I think for the PID community, this is a particularly important thing, within this cohort, there wasn't necessarily a primary immune deficiency cohort, but we found that there was a mutant interferon signature in this barrier tissue that was targeted, that led to was targeted by SARS-CoV-2, and that really led to severe COVID-19 infection. And so what we did is we wanted to know what happened after people got vaccinated, because we started to notice that there were breakthrough infections. Yours truly had a breakthrough infection despite being vaccinated. And so I was very curious to find out. So how did the inflammatory landscape change? What happened to the epithelial cells as a result of vaccinating people? So we had 3 cohorts. So this was our initial cohort. This is the Delta cohort, and we did sequence the virus, and this is the Omicron cohort. And God bless all the people who were willing to act as controls. But as you can see, we had a fair number of folks in both cohorts that were vaccinated, and we did have both moderate or mild and severe disease. And so again, we did single cell sequencing for these. This just gives you an idea of the antibodies. The antibodies were interesting, but not as exciting. So I think, there's been a lot of talk in the media about antibodies, and they're not unimportant. But to me, the mucosal immunology is definitely where the money is, and making it interesting. And the sampling kinetics were fairly similar between all the groups. So again, here's another ink blot. This is the Delta ink blot. So I want you to pay attention to a couple of things. So here in the middle, these are these antiviral ciliated cells. Up here, secretory cells. There will be a quiz at the end. No, I'm just kidding. And then the macrophages are over here. So these are going to be kind of the 3 things. So this part of the ink blot, this part of the ink blot, and this middle part of the ink blot. And this just shows you that the blots kind of look similar. We're still finishing up working on the Omicron. They're doing some additional sequencing, so that's why it looks a little sparse, but it's probably going to look fairly similar. But this is where it's really interesting. Okay, so green is the control vaccinated. We have the unvaccinated folks, so they had some different places on the ink block, and these vaccinated folks really showed up here in this blue areas. So the macrophages, the antiviral ciliated cells, and the secretory cells. But what was really interesting is if you were vaccinated and you only had milder disease, you kind of had more of these antiviral ciliated cells. But if you were vaccinated and you didn't have a response here, you were more in these secretory cells. And then people who were also had COVID-19 or the vaccine and had COVID-19 had more macrophages. You can see the virus down here in purple. It's mostly in these secretory and antiviral ciliated cells, and they're pretty high amounts of virus. So when we looked back at our data sets, we said, wow, that's kind of interesting what's going on here. So if you were vaccinated and you got the virus, the most important thing that seemed to show up was that there were lots and lots, and I apologize, my light went off. There were lots and lots of macrophages in these tissues, whether you had the Delta variant or whether you had the Omicron variant. So vaccination seems to be leading to an upregulation of number of macrophages in these tissues. And it probably overall is helping these epithelial barriers in addressing how virus is handled. So the other thing that I pointed out earlier is that severe COVID-19 is associated with a low interferon response score in the nasal mucosa. So again, we showed this earlier. It was true in the ancestral data set, but it's also true in the Delta data set. And we think it's going to be true in the Omicron data set, but we're still finishing that up, so I can't show you that data. So I wanted to kind of segue back into the GI tract, because this is a GI tract talk. We had to study the nose in COVID because people were super sick and our IRB didn't really want to scope in everybody, which is understandable. And so from a safety standpoint, we had to do that. But I think there's many people probably on this call that are suffering from post-COVID and, in general, and then post-COVID syndromes and their GI tract. So post-COVID syndrome is really associated, there's persistent inflammation, there's altered cytokine protection, there's these persistence of viral antigens, and there's autoimmunity. And in the GI tract in particular, which is what's in gray here, you have persistent cellular abnormalities in the mucosa and the blood. You develop a dysbiosis. We'll talk about what that means in the next section. Altered neuroimmune interaction, and I see that a lot of belly pain, a lot of delayed gastric emptying, new constipation, or changes in gut motility. There's persistent viral antigens in the gut. There's some nice papers that are coming out in inflammatory bowel disease that are showing that. And there's some increase in organs and specific autoantibodies. So I think this whole area is going to be quite interesting to follow. And hopefully some of the research we do will guide our input. So I wanted to segue into the primary immunodeficiency in the microbiome. I get lots of questions about this. So the microbiome in primary immunodeficiency appears to play a critical role in helping the host's immune system maintain homeostatic control of the intestine. Symbiotic flora is affected significantly in primary immunodeficiencies, and there's more dysbiosis in the microbiome. And primary immunodeficiencies are definitely associated with microbial dysbiosis. I mean, I think many of you come into my clinic and you bring me test results, and almost always there's some degree of dysbiosis. And depending on the point in time, it may be slightly different. There's systemic inflammation, and there's this is particularly in the presence of immune dysregulation conditions. And the gut microbiome is a promising area of study for primary immune deficiency, but still very much evolving. So I like this picture because they talk about what the monogenic defects that are in primary immunodeficiency. Obviously, these are not all of them. There's environmental factors. We'll talk a little bit about those later, and some physiological factors, and, including health, lifestyle, obesity. And I like this slide a little bit better, so we're going to segue into that about control of the microbiome in health and CVID. So in health, you've got IgA around. Now, mind you, some people are IgA deficient without, are IgA deficient without having significant problems, but you have control of commensal bacteria because of this. You have an intact gut barrier, and you have limited translocation of bacteria across the gut barrier. And you have adequate induction of a specific immunoglobulins. Unfortunately, in CVID, a lot of these things are broken. So oftentimes there's an IgA deficiency, there's reduced control of commensals, you've got disruption of the gut barrier, you have a lot of bacteria that are coming across, you get some local inflammation, some of those inflammatory cells that I showed you earlier, macrophages get activated, dendritic cells oversample, it's a problem. And then you get reduced ability to have these specific immunoglobulins be formed, and as such, some of these bacterial components get into the blood, and that is problematic. So I get lots of questions about that, or about probiotics. I used this slide 2 years ago, and I'm going to use it again. I think there's really no specific studies about evaluating probiotics in primary immune deficiencies. There's no data to confirm harm. In the IBD literature, there's really a lack of efficacy and an increased risk of bacteremia in patients with weak immunity. So I would say, I would say proceed with caution using probiotics, and in some cases, save your money and go out for dinner. I think this is interesting because I just saw this on Twitter this morning, so I thought that I would post it and put it up here as something that's promising, but also something that you should think about with caution. Many of the people in the PIDD community have experienced C. difficile infection and recurrent C. difficile infection. So I think this is a promising step in the right direction. I'm going to read this quote because I liked it. Today's approval of Rubata is an advance in caring for patients who have recurrent C. difficile infection. And And recurrent CDI impacts an individual's quality of life and can also be potentially life-threatening. As the first FDA-approved fecal microbiota product, today's action represents an important milestone, as it also provides approved options to prevent recurrent Clostridium difficile infection. So I think this is a really cool thing. I think in the primary immune deficiency community, we're going to have to be careful in using it, but I think we've been really struggling, especially during the pandemic, to provide these options. So I think this is a very good step in the right direction. So stay tuned. I wanted to move on and talk a little bit about inflammatory and autoimmune GI disorders. They may be presenting illness for some primary immune deficiency patients. They're really the result of immune dysregulation, inappropriate immune response, autoimmunity, or an uncontrolled inflammation. So these things can include celiac-like disease or celiac disease, IBD, pernicious anemia, gastritis, autoimmune liver disease. And this just gives you some examples. You have common variable immunodeficiency, selective IgA deficiency, and chronic granulomatous disease. And for the purpose of time, I'm not going to read through this. And we've gone through some of these things already. Again, this is just some of the histopathological findings. I'll share the data set this slide set so that it can be posted online. But as you can see, there's definitely some specific things that can happen in the esophagus. We can see esophagitis. In the stomach, H. pylori can be present. There's atrophic gastritis. We'll talk a little bit about moving forward. Intestinal metaplasia is something that we need to pay more attention to in primary immune deficiency. Duodenitis, villus atrophy, increased intraepithelial lymphocytes, lymphoid hyperplasia. In the ileum, you can see ileitis, villus flattening, again, lymphoid hyperplasia. You can see some colitis, apoptosis, TTC7A, actually, you can see a fair amount of apoptosis associated with that. And again, lymphoid hyperplasia. So let's talk about celiac disease, also known as celiac sprue. It's an autoimmune disease due to an inappropriate immune response to gluten. Just because you're IgA deficient doesn't mean you can't have it. Endoscopy shows inflammation and villus blunting in the first part of the small intestine. It's really, the duodenum is the most common place. So, but there is evidence that sometimes people can have jejunal involvement as well. It can be asymptomatic, but may result in malabsorption, weight loss, diarrhea, anemia, bloating, and abdominal pain. And there's an increased risk with CVID and IgA deficiency. And there's also an increased risk with inflammatory bowel disease as well. So celiac disease and celiac-like disease. So the selective IgA deficiency, again, like I said, you can still have celiac disease. Diagnosis can be difficult as the blood tests typically look for IgA-related antibodies. So you can check this this TTG, IgG. It's a little less sensitive, but it's definitely helpful. There's a 5 to 15-fold increased risk compared to the normal patient population. And the treatment is really going to be a gluten-free diet. And I liked this schematic over here on the right. So you can see this villus flattening that occurs, leading to malabsorption. So celiac disease, so CVID, the diagnosis is really made by endoscopic biopsy. There is some genetic testing, and I apologize for this point here, but you want to do HLA testing for DQ2, DQ8. And again, if the gluten-free diet does not work, you're going to have to think about some other options, including glucocorticoids and immune modulators. And then in severe disease, you may end up with malabsorption and nutritional deficiency. And these are some pictures of some scalloping that you can see in the bowel. This is colitis here on the left. And in panel D, this is the ileum and this is the colon. But these are definitely pictures of inflammation in these areas. So what does, I'm going to use that as a segue to talking about inflammatory bowel disease and IBD-like disease. Many of my primary immune deficiency patients came to me because they had inflammatory bowel disease. So traditional IBD is Crohn's and ulcerative colitis. These diseases are characterized by diarrhea, abdominal pain, bloody stools, vomiting, weight loss. Ulcerative colitis really just involves the colon, and it spares the anus, and it's mucosal, so it just involves the surface. Crohn's disease can involve anywhere from the mouth to the anus. There can be extraintestinal manifestations of Crohn's, and you can have significant abdominal pain and malnutrition. You can also have fistulas and strictures. In people that have very early onset IBD, there's frequently an overlap with primary immune deficiencies. So if you come to my clinic and you've had IBD that dates into early childhood, I will frequently send you for an evaluation for monogenic IBD. And again, those frequently have overlaps with primary immune deficiencies. We've diagnosed a number of patients with those over the years. So a few more points on inflammatory bowel disease and IBD-like disease. IBD, like I said, may be a sign of underlying PIDD. Some types of primary immune deficiency, especially those with antibody defects and chronic granulomatous disease, are at increased risk compared to immunocompetent patients. So in selective IgA deficiency, there's a 5-fold increase in classic IBD. Often IBD like disease did not improve with traditional IBD medications. So sometimes we have to get creative. In X-linked achalaomegalobulinemia, IBD enteritis is diagnosed in about 10% of patients. And historically, these patients develop small bowel strictures and transmural intestinal fissuring or fistulizing disease. Unlike Crohn's disease, no granulomas or plasma cells are seen when the strictures are removed surgically. And in this case, IVIG may really help. And some of these patients are going to need parenteral oral nutrition. So there's because this is IBD-like disease, CVID can be kind of indistinguishable, or CVID, IBD-like disease can be indistinguishable from other types of IBD. So biopsies will typically be helpful. And we're typically going to treat similar to other IBD that's arising in non-IBD patients. And again, there are certain caveats to that, certain inborn errors that will require other treatments, but the ones that aren't those specific ones we can use traditional IBD treatments. So I included a little schematic here on CVID enteropathy. So if it's severe, you're going to have weight loss, a severe malnutrition. You can have a lot of IgG loss. You may need parenteral oral feeding, so TPN. You're going to have increased IELs. You can get some chronic norovirus, and you can see some graft versus host disease-like features. And in non-severe CVID enteropathy, things look a little bit better. It doesn't mean you don't have it, but you can have pretty significant diarrhea and some abnormalities on biopsies. This is just a graphical picture showing this. This is just some of the histological findings that you can see. I borrowed this from the AJG paper that just came out because I liked it. So for people with mild CVID enteropathy type symptoms, you can use, simple things like mesalamine, which is a topical it's a topical anti-inflammatory. You can use budesonide. In the case of more severe disease, you may need prednisone, and then you may have to go on and use some other drugs. I have used vedolizumab. I've used anti-TNFs. And then sometimes you have to use alternative biological agents, depending on what the underlying primary immunodeficiency is. But overall, the literature suggests that these are fairly safe to use. So nodular lymphoid hyperplasia, it's a benign condition. It's characterized by multiple small nodules. It's most commonly seen in the small intestine, but it's also seen in the stomach, colon, and rectum. It's typically asymptomatic, but can be an incidental finding on endoscopy. It's associated with antibody deficiency syndromes except XLA, and it's occasionally may be associated with abdominal pain, diarrhea, bleeding, intussusception. And usually when I've seen it, it's been as a result of intussusception, some malabsorption and intestinal obstruction. And this is just a nice picture of it, both endoscopically and on histology. So we talked about liver disease. So liver diseases are common in primary immunodeficiency. It can be up to 24% of patients. This is just an example. So this was a paper that had 35 patients in it. So 63% had an enlarged liver, 60% had sclerosing cholangitis. CVID, there's an increased risk of autoimmune liver disease, primary biliary cirrhosis. I've got a couple of patients in my group that have, and it's really primary. We've changed the name of this to primary biliary cholangitis and autoimmune hepatitis, but there's really a lot of things that have CGG. You can see liver abscesses, hyper IgM. You can see cryptosporidium infection that can occur. And in that situation, you can see a progression to sclerosing cholangitis. So you definitely want to monitor LFTs and GGT in these patients. And if patients have pretty significant changes, whether they develop ascites, they have new features that would suggest liver disease, you want to be fairly aggressive about evaluating those. And people with CVID still are eligible for transplant. So just remember that if you develop liver disease and progress to cirrhosis, it's still a possibility. So CVID can be associated with some cancers, particularly in the stomach. So if you have CVID, you can get gastritis, you can develop pernicious anemia and B12 deficiency. There is an increased risk. And I found that, I think somebody asked me the last time, there is an increased risk for gastric adenocarcinoma. I think it's 4 to 5-fold was it. So you should get an EGD at the time of diagnosis. And then it's really every 2 years. I'll show you that. This data just was in the new recommendations. And then you do want to get testing for H. pylori, which are really done standardly on all gastric biopsies now. Hyper IgM, there's an increased risk for pancreatic, liver, and biliary malignancy. So you should kind of screen regularly, get LFTs, GGT imaging. There's a moderately increased risk with selective IgA deficiency. And again, I borrowed this from the new book. You do want to get abnormal or abdominal ultrasounds every 1 to 2 years. And then you also want to, for gastric cancer, you want to do some initial screening. You're going to check for H. pylori, which we talked about. And then you should do a routine endoscopy every 24 months. And again, last time I gave this talk, somebody had asked me this question and it wasn't there. So if you have atrophic gastritis or intestinal metaplasias, you should repeat it in 12 months. And if there is dysplasia, you want to repeat it in 6 months. So for patients with primary immunodeficiencies, really the standard national guidelines apply unless you have a family history of colon cancer or you have inflammatory bowel disease, and then you're going to follow those guidelines. And the new standard age for screening colonoscopies in people who are average risk is 45. And again, if you have inflammatory bowel disease that's related to your CVID, you're going to get more regular colonoscopies, depending on how long you've had disease and what the extent and activity of your disease is. So malnutrition and failure to thrive are key features of primary immunodeficiencies. Patients have limited food intake, they can have malnutrition or malabsorption of nutrients and increased nutrient losses. This can happen in about, up to 54% of patients. So you want to screen for these vitamins. Iron is common, folate, zinc, selenium, magnesium, calcium, vitamin D, fat-soluble vitamins A, D, E, K, by B12. You want to look for protein-losing enteropathy. So you're going to look for stool alpha-1 antitrypsin. You're going to look at some fecal elastase. You want to think about some of these micronutrients, and daily multivitamin is definitely helpful to a PI patients with GI symptoms. Vitamin D is modulatory properties. I know we've thought a lot about this in the COVID pandemic, but it's still very important. And in IBD patients, low vitamin D correlates with active disease and inflammation. So I would say largely it's something definitely we need to consider in primary immune deficiency. So diet, if you have celiac disease or celiac-like disease, you want to consider a gluten-free diet. There's really no specific diet recommendations for PI patients. There's going to be some individual nutritional plans. You probably want to keep a food journal. And, you know, I sometimes have recommended the specific carbohydrate diet. There's no randomized placebo-controlled diets, but some of my patients definitely find that it's helpful. And I would say it's at least nutritionally balanced. Some other considerations could be bile acid loss, deficiencies of lactase and sucrose. And then in primary immune deficiency, I see a fair amount of secondary mast cell activation. And usually it's related to the underlying condition. So this is just a summary slide to remind you that primary immune deficiency really can affect the gut throughout, from the stomach to the liver to the small intestine to the colon. It definitely causes a gut microbial dysbiosis. And there are lots of things that have to be considered when taking care of somebody with a primary immune deficiency and GI problems. And again, I'm happy to share my slides. And I think I went over a little bit. I apologize for that, but thank you very much. And I'm happy to answer questions. And I'm going to stop. I think I stopped sharing.
Dr. Glover, thank you. Wonderful information. And yes, for those of you who joined us late, this presentation is being recorded, and a copy of Dr. Glover's slides will be available on our website also. And at this time, in addition to thanking you for that great information, before we start the Q&A, just a couple words from a few of our sponsors. So let me pull those slides up here, if I can. So a word from our sponsors: CSL Behring, Grifols, Takeda, Accredo, and X4 Pharmaceuticals. And then after this, we will get right on to the Q&A.
For more than 100 years, we've turned innovative thinking into solutions. CSL's investment in innovation has helped to develop a robust pipeline of safe and effective medicines and improve existing ones so that we can bring patients meaningful innovations and advancements that make their lives better.
Hi, my name is Ricky Mensch, and I'm one of Grifols' immunoglobulin certified nurse educators. As part of Grifols, whose mission is to improve the health and well-being of people around the world, the nurses support the PI community through education of healthcare providers on all aspects of IG care. Our goal is to improve medical outcomes and quality of life. Grifols is dedicated to ensuring that people who need plasma products have access to them. They do this through plasma donation awareness, sustainable supply efforts, and education to increase the early identification and treatment of PIDD. For more information about Grifols, please visit us at grifols.com.
My name is Dana Fladhammer. At Takeda, I am the Director of IG Community Support. You might know the team I'm lucky enough to be a part of as the MyIG Source Patient Advocates. I know that throughout my journey as a mom of 4 children living with primary immunodeficiency, the IDF has been simply an invaluable resource to me. I hope you learn a ton, and if you need us, know that nobody should ever have to do this alone.
Welcome to the IDF Forum. I am Kim Farrell, Product Line Manager with Accredo. Accredo is a best-in-class specialty pharmacy with a nationwide network of immune globulin-trained home infusion nurses and pharmacists. It is truly an honor and privilege to be part of this immune deficiency community. Accredo places patients at the center of all we do. We deliver individualized care and support for patients living with immune disorders. It's all about giving you a great and personalized pharmacy experience.
X4 Pharmaceuticals is developing therapies for people with two types of PIs, WHIM syndrome and chronic neutropenia. These two communities would not have had access to resources like this at Forum without the IDF. We're incredibly grateful for everything that IDF does for the PI community and that we can be a part of it. If you'd like to learn more about our ongoing clinical trials or about our no-cost genetic testing program for those with neutropenia, you can email patientinfo@x4pharma.com. Thank you, IDF.
And thank you to all of our sponsors. Once again, thank you, Dr. Glover, for volunteering your time to be here with us tonight. At this time, I would like to introduce my colleague, Colleen Brock, Manager of Medical Programs, who will moderate the Q&A session with Dr. Glover. If your question isn't answered during tonight's forum, please send it via Ask IDF, and we will do our very best to get an answer back to you. So I am going to stop sharing my slides, Colleen and Dr. Glover, and the two of you just take it away.
I'm going to learn to unmute one day. All right. The normal spiel applies to tonight. Again, unfortunately, we have over 200 questions, so there's no way we're going to be able to answer them all. I will try to get to the most broad questions I can in the amount of time that we have. As always, ask IDF. You can go to the website, submit your question, and we will help you get an answer. So with that, let's get started. I have several questions regarding how to find and have a conversation with a gastroenterologist who understands primary immunodeficiency. So how do you find one? And then what questions do you bring up?
So I would say the first thing is I would look for the major academic medical center in your area. That's usually the best place to start. It's imperfect, and in my opinion, we need to train more PIDD woke gastroenterologists. I'm trying to do that in the folks that I train, but I think across the country there are a number of people that have this expertise, and if they don't, hopefully they know how to get you to someone. I think I would start off by the thing is you want to be very clear about what's happened to you, what's changed. Oftentimes you'll have a diagnosis of primary immune deficiency before you go in. Most of the people, at least in this group, will have that. So you won't necessarily get diagnosed by the gastroenterologist, although occasionally that does happen. But you want to be very clear, these are my symptoms, and make sure that they understand the literature. I think that paper that just came out in American Journal of Gastroenterology is quite nicely done on the GI evaluation of primary immune deficiencies. Frank Ferre at Mayo did that paper. So I can give you the link for that. I'll give you the link to that, but I think it's quite nice. And it's something that you can actually take to your gastroenterologist and say, I have CVID. I'm experiencing a lot of these GI symptoms. Here's the latest recommendations, to help you and I navigate my care.
And that would be wonderful, because that's one of the questions we got is, what can I take to my gastroenterologist who doesn't understand?
Yeah, so this is widely available to anybody who's a member of the American College of Gastroenterology. They can get access to this data. And I used some of this, the schematic I put it up towards the end was from that paper. It's quite nice. So,
And we can include that in the email that all the attendees will be receiving.
yeah, so I'll send you the
Perfect.
link for that.
Thank
And I sent you my slides, so you should have them now.
Perfect.
Awesome.
Are immune deficiencies causing people to acquire GI disorders?
So, like I said, primary immune deficiencies change your immune response in your GI tract. So you have immune cells in the GI tract that are supposed to help you maintain that relationship between the poop that's going through your GI tract or the bacteria that are there and the cells, the immune cells that are in the lamina propria. When you're missing some of the things, when you're missing IgA, when you don't have adequate IgG response that's there, when you have, you don't have enough plasma cells that are making immunoglobulins in response to those bacteria, and more of them make it across your gut barrier, that's a problem. So I would say the GI disease is usually caused by the primary immune deficiency. It's what we call the inside out. So the inside problem is that you're not making enough antibodies, and you don't have the cells there that are supposed to respond appropriately, or they're there and they're just not doing their job.
Thanks. I received a lot of questions about IG replacement therapy being the cause of GI issues. Do you see any correlation?
I would not say that that's necessarily true. I think what happens is you get IgG therapy and you have underlying, because all the other stuff has been going on, you get focused on that. Like, you're used to having your sinus infections and your lung infections and your skin infections, and suddenly you get on IgG replacement. And those things aren't as much of a distraction, and you realize, oh my goodness, I have been having diarrhea 6 times a day, but I was so focused on these other things, or getting antibiotics for these other things, so I thought it was that. And so I think what happens is it's not necessarily the IgG replacement, it's just the IgG replacement, like I said, is inadequate to take care of those things, and you need to have other interventions to take care of them.
Okay.
Yep.
Somebody has asked, what is dysbiosis?
Dysbiosis means that the bacteria in the gut are basically, there's kind of a normal balance of bacteria in the gut that you would expect. And without going into like the different phyla of bacteria that are there, they're supposed to be, you're supposed to have these specific families that get along. But what happens when the gut barrier is disrupted, you get an overgrowth of certain bacteria that shouldn't necessarily be overgrown. So in other words, the families one family is sort of able to take over. And oftentimes when that happens, those specific bacteria lead to disruption of the gut barrier and can traffic across the gut barrier.
Some colonoscopy questions.
Yes.
Should people continue to get them after the age of 70?
It really depends on you. So there's a lot of very healthy 70-year-olds, including my own mother, out there who are, doing really well and are probably going to live to 100. So that, I think the guidelines are now 75 is the cutoff, but you could still really you just need to have that discussion with your doctor and figure, what is the risk benefit? If the risks outweigh the benefits, don't do it. If the benefits outweigh the risks, do it. So it just depends on where you're at. Or if you're really symptomatic, if you're having like massive diarrhea and you have, then it's worth it to do it and find that out and get treatment so you're not miserable.
Can you have severe abdominal pain with your PI, and yet GI doctors miss signs of PI-related GI issues when they do an EGD or a colonoscopy?
Yes, because when you do an EGD and a colonoscopy, the EGD looks at the esophagus, stomach, small, and the first part of in the duodenum, really. And then the colonoscopy looks at the colon and the ileum, but it doesn't really tell you there's a whole bunch of small intestine in the middle that you don't see. And so sometimes you need to order capsule studies. It's a camera that you swallow, or it's placed endoscopically in the small bowel, and it goes through and takes a bunch of pictures. So sometimes you can miss those things, particularly in people with PIDD. And I have a couple of patients like that where we've had to go and dig a little deeper.
And that leads me to my next question. I have two here who have severe reactions to having a colonoscopy. One gets super sick and is on antibiotics after it. One gets super sick on the medication. Both are looking at asking what are the alternatives to a colonoscopy.
So it depends. If you don't have underlying inflammation and you just want it for colorectal screening, Cologuard is definitely available. I have zero financial interest in Cologuard, but it is the kind of standard genetic test for colorectal screening that's available. There are some liquid biopsy things, some blood-based biopsies that are coming for colorectal screening. These trials are in the process of being completed, so I would stay tuned for that. If you have to have a colonoscopy, there are alternative preps that are available. And usually that's something you just have to discuss. You don't always have to do a polyethylene glycol based prep. And I know I do have some patients that are allergic, and our pharmacist usually works with those patients to come up with some alternative preps. If you get sick, so for example, bacterial translocation can occur in normal patients who have colonoscopies. It's even more common in primary immune deficiencies that can happen. So if you know that happens, let your doctor know. And sometimes we can preempt that by giving you antibiotics pre-colonoscopy. Some places don't use CO2, some places use air. I find that the CO2 makes it a little bit better. You don't get as much, distension of the colon. It's less of an abiotic impact on the colonic mucosa, and the CO2 gets absorbed, so that tends to be less of a problem. So ask about that. Do you use air? Do you use CO2? You can you can preempt some of those things.
Is there research documentation somewhere that we can use to ask for an upper endoscopy every 2 years and to justify it to insurance companies?
That is actually in that article. So the one that just got published, which is fantastic. Like I said, I was so excited to see that. I'm like, thank you, Frank. He's a really good guy, by the way. He's at Mayo. I'm giving him some PR, so
That's right.
Yeah, but anyway, so they what was I going to answer that? So yes, so it's in that article, and it specifically has guidelines that say, if you have CVID, you need an initial endoscopy. If you have atrophic gastritis or intestinal metaplasia, you should have a repeat in a year. If you have dysplasia, you need to have a repeat in 6 months. So it's very clear. There's some very clear guidelines now, and this is the first time I've seen that. So I was very pleased to see that.
Is there
insurance companies? It's hard for them to argue because it's well documented.
Is there a relationship between gastroparesis and primary immune disorders?
I don't necessarily know the answer to that question. Definitely, there is a relationship between gastroparesis and enteric viruses, including COVID-19. So if you've gotten viruses because, GI viral infections because of your CVID or your primary immune deficiency, and you can develop gastroparesis as a result of that. So it's more of a result of getting a viral infection is usually the most common reason. And we definitely see a lot of that post-COVID-19. It's one of the bigger things we see.
Interesting.
Yeah.
How common is appendicitis in people with PID, and are the symptoms different from people without PI?
I mean, I don't necessarily know the frequencies, but I would say, it's probably fairly equal to the general population. Yeah, I would say symptoms can probably be fairly similar. You're going to have right lower quadrant pain because it's going to behave the same way. Sometimes what gets confusing, and I've had this happen with patients, if you have overlapping, PIDD related inflammatory bowel disease that sometimes can be very confusing and sometimes lead to delayed care. There's also been some shifts in guidelines in terms of how, people aren't necessarily going to surgery right away. And they're getting treated with IV antibiotics instead of going to surgery. So it definitely is a little bit murkier landscape.
Okay. Any recommendations for treating acid reflux?
Well, I would still recommend that, there's the usual dietary guidelines, go easy on the spicy food, go easy on the caffeine, don't eat too late at night, keep the head of your bed elevated. Those are kind of the standard gastroenterologist recommendation. There's nothing wrong with trying an H2 blocker first. I still think that if you need a proton pump inhibitor, you should take it. I have plenty of patients in my practice that need long-term PPIs. I think we just have to be cognizant that, PPIs aren't perfect and that there are other side effects associated with them that we have to keep an eye out for. So you do need to be followed, and your primary care doctor needs to keep an eye on that when you need long-term PPIs.
I have several questions about small intestinal bacterial overgrowth and PI. Can you discuss that a little bit?
So it doesn't, it's not a surprise. Remember, like we talked about, because the gut barrier is often disrupted, because motility can be affected, because the cells that normally kind of traffic bacteria in the gut and keep it where it's supposed to be at aren't doing their job, you can get bacterial overgrowth in the small intestine. So that's not an uncommon thing that happens in primary immune deficiency. And it's one of the things we frequently think about in treating primary immune deficiency. When we have people come in with bloating and abdominal pain and diarrhea that's not explained by something else.
So we're going to talk about some diarrhea questions. What do you do when you can't leave the house due to running to the bathroom every 20 minutes?
Well, that's not
good.
Live
that's life.
That's a problem.
Yeah,
that's a big problem. So number one, if you can get your doctor or if you can get somebody to pick up, collection containers from your physician and have a family member take them and drop them off at the lab, that's super helpful, right? So that can be helpful to make sure you don't have an infection. And C. difficile, the viruses we talked about, some of the Cryptosporidium, other Giardia, other pathogens that are common. If you have inflammation, sometimes people need to be hospitalized for an evaluation. If you can't get out of the house and you can only make it to the ER, that's what we got to do. We got to do evaluated. But it definitely is something. If you're waking up at night having bowel movements, that's a problem. If you can't leave the house because you're having that many bowel movements, that's a problem, and you definitely deserve a more urgent workup.
What is the best way to prevent flare-ups?
That's a really broad question. So it depends on which type of flare-up you're having. If it's an inflammatory bowel disease flare-up, there's a whole host of things that can cause you to flare, right? Stress can cause you to flare. An infection, including COVID, can cause you to flare. So being careful about, when honestly, wearing a mask can be helpful in terms of preventing some of those flare-ups. If you have dietary triggers that can cause a flare-up, I would avoid those. Making sure that you're consistent in taking your medicines. And sometimes insurance companies make that a challenge for a lot of people. But if you can be consistent about taking your medicines, that can be helpful. Those are probably the biggest ones that I can think of. And then if like stress triggers you, figure out, are there things in my life that I can do to limit those stressors that are going to trigger my disease?
A question that's sort of related to the beginning when I asked you about the GI doctor. This person has chronic diarrhea and CVID, treatment difficult at best, their GI doctor feels there's no connection to CDID as he finds no signs of an inflammatory process during a colonoscopy. How do I tell him there's still a possibility they are connected? Does that go back to that article? Would that
Yeah,
help?
I mean, I would probably refer back to that article, and I would, sometimes it's worth it to get a second opinion. And I don't think that's wrong. And I encourage patients to get second opinions. I mean, I've learned things from my colleagues. So I think if you can, there's nothing wrong with that. And a good doctor will honor a second opinion.
Totally agree.
Yeah.
Also going back to the IG infusions, this person writes, my son gets a gastro upset 6 hours after his infusion. It's like clockwork. Anything he can do to prevent that or help get through it? Gastro stuff is more diarrhea than nausea, but sometimes it has been both. And another person says they get diarrhea. They do sub-Q infusions, which cause diarrhea. And is that normal to have them 3 days after infusions?
Again, it's hard to know about cause and effect, but if it's a consistent thing, you can always take some Imodium around the time of the, your IG infusions or sub-Q injections.
And I would definitely discuss it with their immunologist.
Yeah, I would talk and I would talk to your physician about it. Talk to your
tell
immunologist.
them what's happening.
Yeah, tell them what's happening so they know. Yeah.
All right, so now let's go the other way with constipation.
Yep.
How common with constipation and motility issues? Is it a tendency to be constipated with PI, or is it only diarrhea?
It's not only diarrhea. 20% of people with celiac disease, for example, can have constipation. So if you have celiac-like disease and you have primary immune deficiency, you can be constipated. And then again, we talked about post-viral things that can involve the colon as well. If you're, a woman and you've had a number of children, you can get pelvic floor dysfunction and have constipation related to that. So, constipation has kind of a broad differential diagnosis. So it's really important to kind of sit down and ferret out what is going on, with each individual patient.
And like we talked about with diarrhea, then is like, how do you help when you are constipated, and what do you use?
And it's going to vary from patient to patient. I mean, usually I tell patients, start off with the simple stuff. Drink plenty of water. As long as you don't have gastroparesis, try to get a water-soluble fiber product. There's no reason you can't use a polyethylene glycol product as long as you're not allergic or don't have a problem with it, like Miralax, once or twice a day. Those are safe things to do. Definitely talk to your PCP or your gastroenterologist about it. Make sure that you involve them in that discussion. But again, getting enough fiber in your diet, even prune juice is still a good thing. Not everybody likes it, but it still works. So I think, those are always a challenge. And then as you get into problems with, motility problems related to the pelvic floor, those can be more complicated and often involve collaboration between a gastroenterologist and a colorectal surgeon and a urogynecologist to kind of sort all of that out.
Thanks.
Yeah.
Now let's talk about food and not prune juice.
Yeah.
What are the latest thoughts on going gluten-free, even if you've tested negative for celiac by biopsy?
So there are some older papers, gosh, I want to say it's 2005 we call it the Red Journal, but it's the American Journal of Gastroenterology, that even people with like IBS-like symptoms could sometimes respond to a gluten-free diet. So I don't think there's any harm in doing it as long as you're not becoming nutritionally deficient and you're getting adequate nutrition. I think going gluten-free, if you feel better, why not? It doesn't hurt you.
Is gluten intolerance directly related to the PI, or it could be and it might not?
It may be or maybe not. Sometimes, if you have gut barrier dysfunction and some of those peptides are, they're not getting digested properly and they're making it across, they could be causing issues. So
I had food poisoning 3 times from sushi. Is sushi dangerous for CVID patients and immune system problems? And why do allergies to food change all the time?
So let me answer that two ways. I would probably go easy on the sushi if I had with CVID. Everything, you may want to eat the cooked stuff. And then the second part of that question is food allergies. So, and it's more gastrointestinal food sensitivities, really that occur. So anytime the gut barrier is there, so normally you're supposed to have like 3 grams of IgA that's made a day, and you have all these firewalls that are in place. So in CVID and other primary immune deficiencies, those firewalls kind of get disrupted. So suddenly you have food that's getting digested and some of these peptides are getting across that normally wouldn't. And so as a result, you can have reactions to those things. And that's probably a little bit of a simplistic explanation, but you may be inappropriately responding because the apple cart has been upset.
Makes sense. What was the name of the diet you mentioned towards the end of your presentation?
Oh, it's called the specific carbohydrate diet. And again, no financial relationship to this author, but the original book was called Breaking the Vicious Cycle. And the woman who wrote it, her name is Elaine Gottschall. But I have a number of my IBD patients that like it. The Crohn's and Colitis Foundation actually did a study where they compared it to a Mediterranean diet. While it wasn't any better than a Mediterranean diet, it wasn't harmful, and definitely patients felt better on it. So I think it's reasonable if you're looking for a diet that's nutritionally balanced and has at least some anecdotal benefit, it's one to think about. And it's relatively gluten-free. And it kind of starts you off, you start off simply, you incorporate, Greek yogurt and other things into the diet. So I have a lot of patients that like it.
Cool. I'm confused about the speaker's comment on probiotics. That was the first thing my immunologist put me on, along with my IG replacement. I have had other doctors mention this too. What is her reason for us not to take it?
So what I meant was, I'm not sure how much benefit they have. I don't think it'll necessarily hurt you, although I have a lot of patients who come in with bloating and they're taking all these probiotics and I stop them and that gets better. The problem is we don't really know how some of them work. There's clear evidence in something called pouchitis. There's good evidence for that. But we don't really know enough about how they work to say that this truly has benefit. So in other words, the evidence isn't so great to say that. And I don't want to be critical of other physicians because, I don't think it's going to hurt necessarily, but it may not help. And sometimes you may have some other symptoms related to those.
What if you're on antibiotics?
Yeah, I mean, if you're on antibiotics, I wouldn't take them while you're on antibiotics because the antibiotics are going to probably wipe them out anyway. But I think, after you're on antibiotics, you can do kefir, you could do, some lactobacillus containing probiotics. But in general, I'm not encouraging patients to go out and just buy probiotics and take them all the time because, again, it's an extra expense when you already have a disease that costs a lot of money and which may or may not have benefit. So that was my point.
Okay.
Yeah.
Can IG replacement therapy help gastritis and diverticulitis?
I don't know that it necessarily helps gastritis and diverticulitis. I mean, diverticulitis typically needs to be, often needs to be treated, especially in the setting of PIDD, with antibiotics. Gastritis is usually an inflammatory condition in the stomach that often, is addressed using a PPI unless it's due to H. pylori, and then you're going to treat that underlying H. pylori with antibiotics and a PPI. So, I mean, I don't know that necessarily it would be helpful.
Okay.
In the case of diverticulitis, it's going to help you from having really bad things happen because of your diverticulitis.
Right.
Yep.
So we're going to get into deficiency specific questions. Can a very low IgA be the cause of fructose malabsorption and lactose intolerance?
Well, so when the gut barrier is disrupted, you can actually get secondary deficiencies of these specific enzymes, so fructase and lactase. So that can happen. And once you treat the underlying condition, that you can have improvement. And along those lines, some of these oral IgG supplements, I actually prefer those over probiotics because they help improve chemical gut barrier. Some of the oral IgG supplements, oral glutamine can all be helpful in improving those things. And then if it's not a primary deficiency of those enzymes, some of those things will get better.
Related to specific antibody, what tests do you recommend to understand what's causing problems? My son has SAD and has a recurrent diarrhea and stomach pain and has lost 15% of his body weight in a year.
So I think in that case, he's really going to need just a very meticulous GI workup. You're going to have to, I don't think necessarily a blood test is going to help that. Usually I try to start thinking about when that happens is if he's lost this much weight and you've done an EGD and a colonoscopy, it's negative. I got to look at the small intestine. And then I start thinking about what are disease modifiers? Well, does he have celiac disease? Does he have hereditary, is he Caucasian, and does he have hereditary alpha tryptophanemia along with his SAD? So you start thinking about what are all the modifiers. Does he have a chronic norovirus infection? So you really have to kind of go down that algorithm and work up the disease.
Thank you.
Yep.
XLA. What percentage of XLA patients develop irritable bowel? And what is the proper treatment for infections such as C. diff, Giardia, Campylobacter?
Yeah, so you're going to treat, let's start with the infection part of that question because that's an easier question. I would say probably most people, I don't know the answer necessarily to XLA and IBS, but it wouldn't surprise me if a fair number of patients with XLA had IBS type symptoms, just because again, going back to gut barrier dysfunction and irritation, I think I showed you that slide that showed the barrier and the interaction, at least in the gut, with the enteric nervous system. And so if you have those things, that the enteric nervous system can get irritated, and then you have, I hate the word IBS, but you get visceral hypersensitivity related to having had infections or a disrupted gut barrier. And then in the case of treatment, it really is going to be, treatment is going to depend on what bug you have. So if you have C. diff, you're going to start off with oral vancomycin, and you're going to give people an appropriate course of oral vancomycin. We just saw that FMT product came on the market. Again, that is something that I would discuss with your immunologist before I did it. But I would start off with oral vancomycin. Campylobacter, Salmonella, Shigella, traditionally, we don't necessarily treat with antibiotics. However, people with primary immune deficiencies, the infectious disease doctor may choose to treat. There's definitely a risk benefit to that, and you have to have a discussion. Usually, if I have someone with Campylobacter or Salmonella, Shigella, I will actually talk to ID and just make sure we're in agreement with treatment strategies.
Treatments for XLA and Crohn's.
Oh, well, so I would say it depends, where is the disease at? What's the extent and activity of disease? So is it large bowel disease? Is it small bowel disease? How old is the patient? There's going to be a lot of variables that I look at in relationship to that. I think usually most people are going to, is it mild disease? Is it more severe disease? Again, you're going to have to really evaluate what you're doing.
And I have XLA, have had all sorts of tests, biopsies, fluoroscopies, small bowel follow-through, spent a week in Mayo Clinic, never received anything as a diagnosis beyond microscopic colitis. Been treated with budesonide with Dale and loperamide. every day, and they're still going at least 6 times a day.
So if
Recommendations.
so if you have microscopic colitis that is not responding to standard treatment, so the standard treatment, that is the standard treatment. You start off with, loperamide, you go to budesonide. If you don't respond to it, then you're sort of getting into what I call level 4 evidence. And there's no way we don't have enough people with microscopic colitis or lymphocytic colitis to really have this. So there's no randomized placebo-controlled trials, but there's definitely case-based literature to support using things like azathioprine, tacrolimus. I've used infliximab, I've used vedolizumab. So you kind of get into those and you have to go down that treatment algorithm. And so a lot of times that involves getting to, and Mayo is a pretty good tertiary IBD place. It may be worth it to go back to Mayo. I shouldn't say pretty good, they're excellent. An excellent tertiary IBD place. And so it'd be worth going back and say, hey, this really isn't working. I have primary immune deficiency, which means I'm going to have more autoimmunity. Would you consider starting me on one of these other therapies?
Do you know enough to speak on granulomas that are in the liver?
It depends on kind of, that's a very broad question, because sometimes it can be due to sarcoidosis. Sometimes it can be due, you can see it with like chronic granulomatous disease. There's lots of conditions that have granulomas in the liver. And so it just depends on what is the underlying disease process. But I would recommend, if you're really concerned about it, follow up with a hepatologist. So you want to see somebody who their whole practice is committed to doing that.
Good idea. Are swallowing issues related to CVID? Oh, sorry, we're going to go on to CVID questions.
Okay.
So are swallowing issues related to CVID?
So we're going to do it really simply. So if you have infection, yeah, absolutely. So if you have like CMV or HSV esophagitis, you can have swallowing issues. If you have Candida esophagitis, you can have swallowing issues. So those would be infectious reasons. It's pretty rare to have you can get, I have seen eosinophilic esophagitis overlap with primary immune deficiencies. So that could be a reason for swallowing problems. You could have just heartburn. The most common reason actually for difficulty swallowing is heartburn or GERD. So that could be a problem. We talked about motility problems. Sometimes that can happen. I was just trying to think about my primary immune deficiency contingent. I don't see that as often, but it doesn't mean it doesn't happen. But I would start off with the simple things. Is there an infectious process? Does somebody have GERD? Those would be the two things I would start off with. But I definitely think an EGD is warranted earlier rather than later.
Is autoimmune pancreatitis often found associated with CVID and elevated IgG4?
Yes. Yeah, you can definitely see autoimmune pancreatitis in association with IgG4 levels. And there's a lot of overlap between some of these autoinflammatory conditions or autoimmune conditions. So it wouldn't be atypical to see that. And I think we're getting a little smarter sometimes. Sometimes there's other things that are going on, and what you think is an autoimmune thing is not. And, my patients have done a really good job at making me a better doctor. Sometimes I think it's an autoimmune, pancreatitis, and there's something else going on. So it's important to be really aware of that. But IgG4 can be elevated in autoimmune pancreatitis.
How does all this head spinning info relate to IgG over 10,000? So what kind of GI symptoms would somebody with an IgE level of over 10,000?
Oh, unless they're talking about it depends. So I think we're getting into Job syndrome, kind of hyper IgE syndrome, STAT gain of function mutations. You definitely can see GI. I mean, I have a couple of patients that have, stat gain of function mutations and elevated. I don't think I have one. I have one hyper IG patient in my practice. But most of the stuff that I see tends to be more inflammatory, in the skin and in the GI tract.
And another question about the liver. What do you do for an enlarged liver that is extremely painful?
The first thing you want to do is get a liver ultrasound. Make sure that there are no lesions in that liver that's explaining why it's increased, and that the blood flow to the liver is not compromised. Because one of the things you have to worry about is is there a blood clot that's preventing adequate drainage of the liver? So if that's a problem, you definitely need to get the liver imaged and figure out why it's enlarged. And sometimes you may even need to biopsy the liver if that testing isn't revealing.
And what are your thoughts on unexplained weight loss? If you have normal endoscopies and colonoscopies and they're negative for infection, and the doctor just says that's just because of your CVID.
Yeah, I would say I would dig a little bit deeper. I would look for exocrine pancreatic insufficiency. So get a fecal elastase. I think I included that on one of the slides. So look for exocrine pancreatic insufficiency. Again, look at the small bowel. Don't forget about the small bowel. It's not uncommon that people just kind of forget about that. Check other things. Is your TSH normal? Did you suddenly develop thyroid disease that you didn't know about? So there's other reasons that people can lose weight that you have to consider that are outside of the GI tract.
And unfortunately, we're going to go with the last question. You talked about PPIs and being on them for a long time. This person states their mother and grandmother died of stomach cancer. She's been on them since she was 38.
Mm-hmm.
How worried, and I know a lot of people are very concerned about being on them for a long period of time, but yet can't function or are not comfortable
going off of them. Yeah. So I think again, this is where you have to have a close relationship with your GI doc. And really, if you have a family history of stomach cancer, you need regular evaluations. You've got to have regular endoscopies to make sure that you're not, developing stomach cancer. If you don't need them every day, you could go to every other day. I can't afford to not take my PPI every day, but some people don't need it every day, so they can take it when they need it. We used to think you had to take it every day. I think in reality, you can take it kind of as you need it. So.
And any last words of wisdom? There are so many questions, and I wish we could answer them all, but words of
great
wisdom,
questions. Thank you.
They were very good, and there's even more that are really good, and people who desperately need help and desperately want answers to their questions. So any pearls of wisdom for those patients?
So I would just say, be, when you go to your physician, be methodical in the questions that you ask, put together a timeline. There's a couple of folks who I know are on this call that are excellent at doing this. Put together a timeline of your symptoms. If you have a doctor that isn't used to seeing primary immune deficiencies, you can actually, provide them with some information on those things. If you're really struggling, try to get to an academic medical center or a tertiary care facility where you can get the things that you need, and just realize that this is a shifting landscape. Part of the reason I presented the COVID data is just to show you that, the science is moving forward and that we're learning something new every day. So just know that the treatment options you have today may be very different tomorrow and may be significantly improved because of the questions you ask and your involvement in societies like the IDF. And I thank you all for being so involved. And my kid just locked the dog in here. Great. At least they didn't pop popcorn this time. Last time I presented, somebody decided to pop popcorn and get on the Stairmaster. So yeah. Thank you so much.
Thank you. Amazing information. Thank you so much for being here with us and sharing your information. Send your slides over to me and I will make sure that we get a copy of those out with the recording, and enjoy the rest of your evening.